Welcome to The Blend, a podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants. In this episode, special guest Dr. Apple Bodemer, a dermatologist at the University of Wisconsin, shares her unique approach to treating alopecia with Dr. Sonal Choudhary.
Hello, everyone, and thank you for joining the Blend podcast. Welcome to all of our advanced practice providers, physician assistants, nurse practitioners, and physicians in dermatology, and any other specialties who want to learn more about integrative dermatology. We really hope that we're able to provide some unique insights about what is up and coming in integrative dermatology. Today, we are tackling a topic that has become increasingly important and somewhat challenging: alopecias. I am Dr. Sonal Choudhary, a dermatologist, dermatopathologist, and integrative dermatology trained physician, and I'm very, very excited to be joined today by Dr. Apple Bodemer. I would like to tell you that Dr. Bodemer actually finished her medical school and dermatology residency at the University of Wisconsin and then completed a fellowship in integrative medicine at the University of Arizona. She was the first dermatologist to be board certified in both dermatology and integrative medicine and has served as a member on the Integrative Medicine Board. She has also authored academic texts, has made curriculums, spoken widely on a variety of topics, especially alopecia, and she loves to explore lifestyle choices that impact skin health and disease. So who better than her to have her on this podcast? And she is also board certified in lifestyle medicine. So we will be asking her a lot of questions about that. Personally speaking, I know that I have learned a lot from Dr. Bodemer as being one of the fellows to learn from Learn Skin IDCP program. So I really welcome her today and would like to learn more from her about integrative dermatology. And please share a little bit with us, Apple, about what drew your focus to hair loss and what was your journey like in integrative dermatology?
Well, kind of my background in integrative dermatology really came from a couple experiences I had in my dermatology residency, where I had the opportunity to travel to India, Nepal, and China and see firsthand how other forms of healthcare and healing practices are practiced right alongside Western medicine in those countries. And coming back home, I thought, well, why can't we do that here? And after my residency, I sought out the Integrative Medicine Fellowship, and because that's exactly what integrative medicine is all about. And I was really excited to bring that practice and philosophy to our patients with skin concerns and conditions. And so it really is looking at the whole patient, where they are at a point in their life and their health journey, and coming up with treatment plans that draw from the best that a variety of different traditions have to offer in order to optimize their health and well-being. So that's a little bit about integrative dermatology. In particular, hair loss piqued my interest because as a young resident, I have very culturally, acceptable hair. It's long and kind of wavy, and I get up, go to bed at night with it wet. I wake up in the morning. I didn't even own a brush or a hairdryer until I had kids, and I just went about life. It was really one of the privileges that I didn't know I had. And I had a hard time understanding these, middle-aged and older women who were sitting across the table from me, often in tears. And I kind of, as a young woman, thought, well, hair is just dead. What's the big deal? And as I traveled through my career, I mean, of course, I had empathy, and of course, I didn't say that out loud, but it was something that I was really trying to understand why such a social impact and such an impact on quality of life. And one day I was sitting in my clinic. I had two young patients who had alopecia universalis, and that's a condition where people lose all the hair on their body. These were both teenagers, and I watched how each of their mothers in particular handled it really differently. And in one case, this young girl had a mom who's like, yep, you just don't have hair. And she was dancing and competing and doing all kinds of things, and it was just sort of a blip in her life. It wasn't a major deal. And the other situation, it was devastating. And the mother was in tears and crying and just felt really invaded by all the questions about her child's health and the assumption that that child had cancer. And, just it was really interesting to me to kind of see it through that lens. And so I thought, I really want to understand this better. So I shaved my head for 4 months. And this was 2018. I committed to 4 months so that I knew I couldn't just say, I'm tired of this, I want to grow it back, because I knew my hair would grow back. And I knew that I could never really understand what it is to truly lose your hair in that way, but I wanted to try to understand better. And that brought up a whole bunch of interesting questions. And there's things that I learned even outside of hair loss, really questions about privilege and what it is to walk in this world and have people look at you in a way differently than you see yourself. And, it really helped me understand why hair is such an important part of our self-worth and self-identity. And it really just gave me a deeper understanding. I was always interested in hair, and it was always one of these things that I was one of the few derms that was really happy to see these patients when a lot of my colleagues hated it. I had some colleagues, you could see their blood pressure rise when they saw hair loss on their patient list for the day. And I kind of was like, well, I like taking care of these people. I like helping them through it. And so that experience really sort of pushed me even further forward and kind of landed me as considered an expert in the field of integrative hair loss. And certainly there's a lot of other hair loss experts that have different training than I have, but I do think I bring a little bit of a unique approach to it.
You absolutely do. Thank you for that. I did not know that story. It's pretty bold to take that approach, I'll say, and also at the same time very humbling to hear. Not to digress too much, but I grew up in India, and I had an androgenetic alopecia spurt. I'll say I call it a flare or a spurt because it does tend to stabilize sometimes on its own, right? As a 17-year-old who had just gone into medical school, so I thought I knew stuff, and then and I saw a dermatologist who was not empathetic at all, and not to go into details, but he was a bald male, and so his sentence to me was, when he saw me in tears and being upset, was that hair is optional. Okay. So to kind of reiterate to how you saw that one patient's mother was totally fine with it and didn't have any, because it's not talking about your heart, kidney, liver, something very, organ system based that is vital to life. Hair is optional. All of us have different hairs. We groom it differently, do different things, different times. So when he said that very bluntly, it didn't work well for me, obviously, as a 17-year-old with hair thinning. But even to this day, that has stuck with me. Using topical minoxidil that drips down your skin and gave me facial hair, and then I had to do laser. Like, it's all a ripple effect after. But somehow, in a making the situation light way, I bring it up to with my patients and tell them this exact story to almost every hair loss patient who seems to feel taken aback by what is going on. I say, this is what they told me. I know this was not the right thing to say, but there's some truth to it, and let's stick with that truth and help you reduce your stress about it. So with that in mind, I want to ask you, how do you support your patients when you see them being very heavily socially impacted or stressed about it? What do you say to them? What is your approach about it?
I mean, my approach in general to healthcare is really meet the patient where they're at. And so when the patient is really distressed about it, my approach is to acknowledge their distress and acknowledge how important hair is to them, and acknowledge that there are aspects of their life that feel, a lot of times it's a loss of control. A lot of times hair loss is associated with other losses in life, especially some of them that are more tightly tied to stress, in particular alopecia areata, but telogen effluvium as well. And so I'll ask them about what else is going on in their life. And sometimes that really helps them to understand, like, oh, there is a reason for this, or just I can understand, that this is a connection with other things. Because a lot of times if it happens, people just think, why me, why me, why me? This is terrible. How did I end up with the short end of the stick? And asking them about their family history, and if that had ever been something that had happened in their family history, that can sometimes help them get a sense of, like, is there, just to put it in perspective a little bit. And I agree, at some point I bring it up. Usually if they're in tears, I'll just sit and breathe with them for a little while and then try to bring them out of it. And if I meet them where they are emotionally, not that I get tearful and kind of wrapped up and join them, but kind of meet them so that I can pull them out of that. And then I will say, all of this it's dead once it leaves the scalp. And, what we're trying to do is maintain the hair that you have, and ideally we can kind of help what's going on underneath the scalp and get some regrowth. And I think that's an important thing to let them know too, because hair growth and hair loss is a slow process. And when we are treating hair loss, it's often 6 to 12 months before we even see a benefit. So people will come in, they've taken high doses of vitamin D or high doses of biotin because that's what they read about, or they've been putting minoxidil on their scalp for 2 to 4 weeks and it didn't work, so they gave up. And it comes from a place of being desperate, that we sort of hop from thing to thing. or treatment to treatment, and just helping them kind of ground themselves and acknowledge the loss. That helps, I think, people start to come to some acceptance. And for some people, it happens faster than others. And it is just something, and some people never get to that acceptance. But I find if you can help them come to an acceptance of where things are and let them know that you're going to work really hard with them and partner with them to try to get things better. I also do talk about wigs early on and hair pieces and toppers. I think when somebody comes to me with really late stage androgenic alopecia, or something that's very late stage, and or scarring alopecia, it's important to acknowledge the truth of the fact that it's probably never going to grow back, and that there's parts of this that we can't fix once we've already been kind of far enough down the path. And then helping them understand that wigs aren't so bad, because you say the word wig and they freak out and they think it's their grandma's purple stiff wig. And hair pieces and wigs are beautiful these days. And I have one patient who struggled and fought, finally came to a place of acceptance. She has a red wig, a blonde wig, a brown wig. She even has a purple wig. And she just gets up in the morning. She's like, what color do I want to be today? And she's really embraced it as something that's added more fun to her life rather than taken something away.
Again, not to digress too much with my own stories, but I love to do that sometimes. I cannot curl my hair for the love of God. And I love people's curly hair and how pretty it looks on people who have it and take good care of it. My hair does not curl or hold curls. And since as a child, I've tried to do it and it never works. So I realized that buying a hairpiece or wig that will do that for me and just play with it and have fun with it on a day I want to wear it. I've not been very good with it. I've not done a good job with it, I'll say, but definitely I see where the fun part comes into that. 100%. And like you said, it is not uncommon, and meeting them where they are, sometimes sharing your own story or somebody else's indirect story, or connecting them to a group where they can find similar ideas, can be very helpful. Because after all, I'll tell you this, that from some of the prevalent studies have shown that androgenetic alopecia affects about 50% of men by the age of 50. It was a very big number. And about 40% of women, and even alopecia areata can happen about, it has like about a 2% lifetime prevalence. These are all non-scarring alopecias, and scarring alopecias are a little bit less common. But of them, CCCA, which is central centrifugal cicatricial alopecia, affects about 3 to 5% of the Black women population. So they are not very small numbers, and people can definitely see and find other people. One of the more recent review papers on female pattern hair loss from 2022 from Din and Sinclair, they stated that fewer than 45% of women go through life with a full head of hair, which was basically implying that hair thinning is quite common. So, I mean, there's a good construct already available for people to understand, and we can help them as providers understand. One of the harder thing as a provider sometimes is to get in that state with them, like you were describing. And I think that is a very critical thing you highlighted that people can take and learn pointers from. So thank you for that. We all know from our textbooks and what we have learned that alopecia is often divided into inflammatory and non-inflammatory, or autoimmune, non-autoimmune types of alopecias. What is before we go into like how we manage them and some integrative approaches about them, when you first meet a patient with alopecia, what are some of these root causes, for the lack of a better word, and no pun intended, root causes, my little pun joke there, but of hair loss that you consider, and how do you approach that? Like, do you start talking about those things right away, and what are those things?
I mean, so first of all, with any patient with hair loss, I have a small set of labs that I'm going to get. And my small collection of labs includes a vitamin D level, an iron, and a ferritin. And I know there's some argument about whether or not we need the iron level, but ferritin is what we call an acute phase reactant, which means that inflammation in the body can sometimes cause ferritin to be high. It's also a measure of the iron stores. So it gives us an idea. So the iron itself could be in the normal range. Your body's going to fight really hard to keep the iron in your blood and in a normal range. But if your ferritin level is low, then you could be dipping in and out of deficiency throughout the day. And when we check a blood draw, it's always a point in time. So I like to combine the two. And if I see a really low iron and a really high ferritin, then I really don't trust the ferritin as well. And because that tells me that there's something else driving that ferritin level to be higher. But if I see that they're about the same, then going forward, I'll just check the ferritin level and I don't check the iron. If not about the same, but if I feel like they're, sort of equivalent, that the iron level is mid-range or a little on the low side and the ferritin is a little on the low side, then I think they do correlate and I'll use that ferritin going forward. But at baseline, I check both. And then I also check a thyroid. I generally don't do a full thyroid panel unless somebody has a strong, unless they're having symptoms that really make me think about thyroid disease. In particular, when people have thinning of we call it the lateral eyebrow thinning. So the outside of their eyebrows, if that's really thinning a lot more than the medial or inside part of the eyebrows, then that's something that I always want to think about. Could there be some low levels of thyroid? And I might check a whole panel, because sometimes even if the thyroid level, like the screening test, comes back normal, that TSH, which is a thyroid stimulating hormone, if that comes back as normal, they still might have antibodies or other reasons why the thyroid hormone might not be functional in the body, or that thyroid test might not be completely accurate. If there's a strong family history of thyroid disease, that's another situation where I might check a full thyroid panel. The other time that I might do it is if I look back and I check their thyroid and I see, usually people get that checked every so often if they're going to the doctor on a regular basis, and especially women postmenopausally, it's often checked every year. It's often checked out every year in terms of childbearing age too, because of the impact that can have on a pregnancy. And if I see that it's been all over the place and they're not, on a thyroid medication, then I might think about a thyroid panel. But that's my short four. Depending on where patients are at, that's usually where I kind of am stopping for my just general practice in academic medicine. Some people want to do gut microbiome testing. And if there's, right now, the gut microbiome kind of hair loss connection is something we're still learning a lot about. And so I don't feel strongly that I'm going to push for gut testing in my hair loss patients unless they're also having other GI symptoms, or there's something else that clues me in that there might be something going on. Most of those tests are at least partially out of pocket. And so that's something to do. If, some people want to look at hormones, I am not an expert in hormones, especially around postmenopausal and perimenopausal. I do have a naturopathic doctor that I'll send them to, because she can spend a lot more time with them, go through the testing that's available. And, if there's a lot of hair growth in other parts, so loss on the scalp and a lot on the face, then I sometimes will test a traditional testosterone and DHEAS just to see where they're at, to look for that hyperandrogen syndrome type picture.
Thank you for explaining all that. Actually, that was going to be one of my questions for you, and how you approach that. Yeah, hormones are hard because, sometimes you do them and you do a big panel of things. It kind of opens a can of worms, and then you have to analyze them and interpret them in that context of every single patient. And that is a whole other science. I'm learning more about it, and we're starting to do a little bit more in my integrative practice in my clinic. But it is challenging. And you will often refer either to endocrinology or a functional medicine provider. We also have them and naturopathic providers available in our collaborative group. So it is very, very important and helpful. A couple of quick clarification questions for what things you were saying. When you said whenever you sometimes will do the full thyroid panel, what does that look like? What are the things we're talking about in that?
Yeah, well, I check a TSH, I check free T3, free T4, and then I check the antibodies, the TPO, the thyroid peroxidase antibody, and help me, I'm blanking.
Thyroglobulin.
Yeah, the thyroglobulin.
Yes. I always blank on that one too, so I was ready. Okay, and then you already said about you ask about hair growth or hair loss in the other parts of the body too, right? Because in certain conditions we can see that happen. So I did take note of that. But do you check labs on all of your patients who come in for any kind of alopecias, or there's a criteria for that?
The top four, I'll look back and see if it's been done within the last year. For acute hair loss like telogen effluvium, I will check, especially if it hasn't been done since the episode of the telogen effluvium. But I would say I'm either looking to see if they've been drawn, or I draw them. Sometimes vitamin D is tricky in terms of coverage, and so that's a conversation I have to have with patients. One of the reasons I really look at vitamin D, we know that vitamin D levels are lower in people who have autoimmune disease. So for those autoimmune related types of hair loss, I do think that's important. And vitamin D is really important in the hair cycle and helping hair go from the resting to the growth phase. And so when I'm thinking about that, when I'm trying to get optimal hair growth, vitamin D is important. So usually if I explain that to patients and explain the reason I want to know is because even if you're in the low normal range, it's not going to help us get optimal hair regrowth back if you're low normal. I like to see levels around 60 in my lab. The range is 30 to 80. I think if I see levels like 120, I'm backing them off. I don't think vitamin D more is always better. I think we want to kind of stick to that 60, I don't kind of like maybe the mid 50s to the 70s range is where I feel the most comfortable. And it's important for other parts of health too, in terms of cancer prevention and mood, especially living in the upper Midwest where I do, and people have seasonal affective disorder and all of that stuff. I think vitamin D really is an important thing to pay attention to.
I mean, it's part of my panel. I know you have a very nice tight panel. Interestingly, I have a very big hair loss panel, and it's written in a very bad handwriting in one of the places in my clinic. So residents often will go and take a picture of it and then order it. But anything that was done very recently, obviously I don't repeat it, but my panel does have vitamin D in it, and I check for zinc. And when I check for zinc, I always try to check for copper alongside, because you know how they're antagonistic. So in order to know what somebody's baseline copper is and if it requires replacement or they just run high, I will check that as well, because same thing for cellular function, zinc is quite important too. What else do I check? I definitely check the thyroid panel in its entire glory. Not if there was done or any of that was already normal. The iron panel, and I do check an ANA. I have found that whenever I check ANAs, I have been able to catch people who have brewing autoimmune conditions. I don't take any major action if it's not beyond 1:80. If it's 1:80 or lower and nothing else is showing up, we just stop there. But if it is a huge number, like 1:640 or something, this I have been able to get people to rheumatology for a further in-depth rule out type of evaluation, and people have caught things earlier than they would. So just to make sure that we understand, sometimes like autoimmune things are taking their time and they're brewing and they have not showed themselves. I have found ANA to be helpful, and I know I get a lot of backlash for that. So
yeah, and I think for me, when it is a little bit different, that the core is what I do sort of for everybody, but there are things that I will add in terms of different specific types of hair loss, and or patients who might be on restrictive diets. And now we're seeing a lot of deficiencies in people who are on the GLP-1 medications, and so that's where I will kind of pick and choose from my panel. I think ANA is a tricky one because you get a 1 to 160, and that I don't feel is very, I see that a lot, like 1 to 180. But I also see a lot of 1 to 160, and I don't get too worked up about it. If it's 1 to 320 or above, then I'm worried about it. But the amount of anxiety that I've ended up causing over the course of my career in terms of people who get a 1 to 180 and they freak out, and then it sort of is not something that I'm going down. But if people have, if they've got one of the autoimmune types of hair loss, then and they're having some symptoms like joint issues or something that's just a little bit out in that review of systems, that suggests that that's when I tend to order the ANA. The other thing to comment on is metabolic disease. And my androgenetic alopecia patients or genetic patterned hair loss patients, I will check a HOMA IR on them. And that's a fasting glucose and a fasting insulin. And that gives us a good idea of risk for developing metabolic syndrome, which includes diabetes. And usually I'll just do a fasting lipid panel because it has the fasting glucose in it. We can also check triglycerides that are going up, and then that fasting insulin. That's a little bit unique, and that's not generally checked by most primary care doctors at this point, but I think that's becoming more and more widely accepted. We do have some data that people who have the genetic patterned hair loss do have there's an association with metabolic disease. And I think because of this epidemic we're seeing of metabolic disease, it's something to really at least consider. And it's tricky because a lot of my patients who are coming in midlife, they already have metabolic disease and they know about it. So it doesn't really help to check that. But when I catch a young man or a younger woman who is having genetic pattern thinning, especially, early in life, I've gotten to the point where I always check that, because that can help give us a conversation about diet, and that's going to impact more than just their hair. And they're seeing all around the impact that metabolic disease has on their family members, and I think that's a really powerful tool that we as dermatologists can intervene on a really incredibly pervasive systemic disease, and hair loss is one of the ways that we can catch it early.
Do you ever do HOMA IR for them? Do you ever do the fasting? You do that, right? Okay, so just for the listeners, the HOMA IR is basically a testing that IR is insulin resistant, and you can order a fasting glucose and a fasting insulin level for your patients. And you can use a simple calculator available online. It's just a ratio of the two that gives you a number that tells you if they're leaning towards insulin resistance or not. And that can really open a big set of options that you need to also address, because you're trying to help them fully, if they are dealing with insulin resistance, that definitely impacts their hair as well. So that is important to know and handle. One more question about labs. Do you ever tell your patients to stop taking biotin before they go get their labs drawn, especially if they're taking like more than 10 milligrams or something?
I think lower than 5 milligrams, and I don't recommend biotin for hair loss. Biotin does not cause hair regrowth. That's a myth that's out there, and people believe it strongly. And biotin is cheap, and it's in a lot of different supplements. Biotin can strengthen the hair and nails in some people. And what I've seen in my practice is if you're on it for more than a year, you might notice that. And that's a might. And if you take it for 6 months, you won't really see it. And I used to think like, oh, it only helps about half of people, but it helps the people that are on it longer term. The data really doesn't support that anything more than 5 milligrams is necessary, and that in fact as low as 2 milligrams is enough to get the benefit. And it is a tricky one, because TSH, the thyroid stimulating hormone, is one of those tests that biotin, high doses of biotin, can impact and give us a false reading on. And so a lot of dermatologists are like, just stay away from biotin, don't take biotin, and biotin is bad. I don't have that approach. I just am really careful to counsel patients that you want to make sure you're not taking more than 5 milligrams, and you need to read all of the supplements, because the supplement stacking kind of is the same as polypharmacy. We can have polysupplement where somebody's taking a multivitamin that has biotin in it, they're taking a B complex that has biotin in it, and they're taking a hair nail supplement that has biotin in it, and pretty soon there are these really high doses of biotin. And biotin in itself is not dangerous. The danger really comes in how it can impact lab values. And TSH is one thing, okay, that might send us, think we're okay when we're not, but troponin in particular is one of the others, and that's a dangerous one. And there have been cases of women who've gone in with atypical chest pain, who are on high doses of biotin. They check a troponin, which gives us an idea about the risk, if they're not having a heart attack or not. Their troponin level comes in the normal range, and they go, and in particular, these cases of women have gone home and have fatal cardiac events. And that level looked normal because of the biotin that they were taking. So that's where the danger comes in with biotin. I think if they're taking an appropriate amount, less than 5 milligrams, it doesn't really affect the labs. And I don't make them stop all of their biotin, but I do tell them, we've got to make sure you're not on high doses of biotin, and we need to keep you off of the high doses of biotin.
Yes, you mentioned troponins, and I went down a rabbit hole just to learn about a little more on this topic recently. Biotin, I think because it kind of fights as a substrate in lab testing values, and there's a couple of different types of common tests that it can interfere with the analyte. And these testings are like these sandwich type of assays or competitive assays. So it can impact troponins. It can also impact like levels of other smaller molecules and vitamins and hormones that are being measured, like you said, like, TSH and stuff. So again, I have a slightly more stricter policy towards this, just because sometimes I can't rely on the patients telling me what they're taking, how many different things. If I'm seeing a patient who is giving me the indication that they take a whole bunch of things on their own, and I don't know how much biotin, I just tell them, just don't do your labs yet. Just stop whatever you're taking. Give it 10 days or so, then go and do your tests. And it just kind of puts us in a better place with that. But
yeah,
thank you so much.
I agree, because if some people know exactly and some people don't. And if they can come in and tell me, and if they bring their supplements with them, and I can see like, oh, this is a low level, you're only getting in one supplement and it's okay. But if they've got this huge bag and I can see that there's 2 different hair nail supplements in it, then I do the same thing. I kind of just I sort of tailor it a little bit that way.
We hope you enjoyed this episode of The Blend. Thank you for listening. We'll see you back next time.